When most of us picture physical therapy today, we imagine a highly polished 20th century innovation. We think of sports medicine, bright clinics filled with resistance bands, foam rollers, and structured post-surgical rehab. But jump back to ancient Greece and Rome, and the treatments looked entirely different. Physicians like Galen treated severe joint pain and gout by dropping live electric torpedo rays directly onto patients. They used the violent bioelectric shock from the fish to numb the patient's nerve pathways. Curiously, by the late 18th century, the focus shifted toward mechanical orthopedics with the invention of the gymnastikon. This massive apparatus of wooden cranks and flywheels was designed to forcefully exercise joints affected by gout and chronic stiffness. For 2 millennia, these disparate interventions, manual manipulation, bioelectricity, and mechanical cranking, existed as a disjointed collection of experiments. Without a unified medical framework or a standardized profession, rehabilitation remained erratic and unorganized. The specialized clinical science of physical therapy was forged on the front lines, built through a series of desperate responses to humanity's most extreme physical traumas. The first genuine attempt to organize these practices happened in early 19th century Sweden. A pioneer named Per Henrik Ling started experimenting with structured passive and active movements to treat chronic impairments. Ling founded the Royal Central Institute of Gymnastics to teach his methods. The government officially registered his practitioners, giving them the title of sjukgymnast, which translates to someone who conducts gymnastics for the sick. While Europe laid this academic framework, it took the outbreak of World War I to turn physical therapy into a global necessity. Modern trench warfare introduced high-velocity explosives that shattered human bodies on a massive, terrifying scale. Military field hospitals were completely overwhelmed. Thousands of soldiers were surviving with extreme limb trauma, nerve damage, and amputations. They needed immediate, large-scale rehabilitation just to function again. The U.S. Army responded with a radical solution. They created a brand new civilian medical unit entirely made up of female healthcare workers, called the Reconstruction Aides, deploying them directly to field hospitals across Europe. Mary McMillan, trained in England, became the first official Reconstruction Aide in the U.S. Army Corps. She took charge, developing standardized military PT protocols and writing landmark textbooks for therapeutic exercise to establish rigorous clinical guidelines for the profession. World War I proved that physical therapy was a critical, life-saving branch of military medicine required to reconstruct a broken generation. Just as the global war concluded, the medical community faced an entirely different crisis: widespread poliomyelitis outbreaks. Polio paralyzed tens of thousands of children globally. Because medical science had no vaccine yet, physical therapy became the primary defense against muscle atrophy and skeletal deformities. The standard medical consensus of the era was to handle the paralysis passively. Doctors locked patients' limbs into rigid, unmoving plaster casts to prevent bone deformities. Sister Elizabeth Kenny, an Australian nurse, looked at these immobilized patients and completely rebelled against the medical establishment's techniques. Kenny rejected the casts entirely. She used hot, moist compresses to relieve muscle spasms and guided her patients through active range-of-motion exercises to keep the paralyzed limbs moving. Her active methodology caught the attention of U.S. President Franklin D. Roosevelt, who was locked in his own highly visible battle with a paralyzing neurological illness. Seeking relief, Roosevelt purchased a resort in Warm Springs, Georgia, and transformed it into a massive hydrotherapy center for polio patients. His direct involvement propelled physical therapy into the global public consciousness. The sheer scale of the polio epidemic forced physical therapy to evolve. The field stopped treating patients as passive objects in casts and started empowering them as active participants in their recovery. By the mid-1950s, the acute crisis era finally broke. The discovery of the polio vaccine meant the medical system no longer had to mass triage thousands of paralyzed children. But the infrastructure of therapists and protocols built over decades of war and pandemic remained. This allowed physical therapists to step out of military wards and expand into civilian outpatient clinics, universities, and public schools. In 1974, the profession formally fragmented into dedicated scientific disciplines, branching off its first official specialized section for orthopedics. From there, the clinical science expanded into the focused subspecialties we rely on today, including cardiovascular, sports, pediatrics, geriatrics, and neurological rehabilitation. It is a long journey from throwing live electric fish onto painful joints or cranking limbs with wooden flywheels. A modern physical therapy appointment is the culmination of a resilient medical science forged in global tragedy, a discipline operating on the clinical reality that movement is medicine.